All right, got the mic on. Can you guys hear me all right? Looks good. So I'm going to talk a little bit about the HPV work as Miles mentioned, and kind of start by talking a little bit about just kind of the history and background of practice-based research networks. And then we're going to talk about some of our community engagement strategies that we've leveraged within our research networks, and how we've utilized a lot of our community partnerships to help with our translational research and dissemination and implementation. And then really specifically use those frameworks to talk about what we're doing currently around HPV vaccination. And so this is part of an ongoing study. So we'll be able to show some of the preliminary results, talk about the next steps, and then hopefully leave some time for questions and answers with you guys. So we do a lot of work out in the communities in Colorado, both in the practices, the sort of real world primary care outside of the ivory tower, as well as just with community members, patients, and everything in between. Free range humans is what we typically like to call them, just folks without any sort of an affiliation or role. And with that, we always like to do very long, thoughtful introductions in order to kind of really break the ice and establish a relationship. And so to build upon some of the professional information that Miles shared with you, I thought I'd tell you a little bit about myself. So in addition to being a family physician in practice over at A.F. Williams in Stapleton, one of the UC Health clinic sites, as well as a researcher here on campus, I'm also a big coffee nerd. One of my more esteemed talks was at the Denver Nerd Night on the science of brewing coffee. That was back in, I think, 2014 now. So it's been a downhill slide in my career ever since then, but I still drink coffee regularly and brew a lot. I have a lot of knowledge about the science and chemistry of coffee. And I am an avid cyclist and recently a bike shop owner. So my friend and I, who I did residency with, he and I opened a bicycle shop this past May. We had been doing some work on the side for several years, but finally decided to actually become an LLC in part to protect our own liability. So Infuego Cycles is the name of our business. So if you guys need healthcare, cancer prevention research, PBRNs, or a bike tune, you can contact me for any of those things. Now, typically, we'd pass it around the room and have everybody else introduce themselves, but it's not feasible. But I do want to get a little show of hands. So who here is familiar with practice-based research and our practice-based research networks? Okay, that's about what I expected. And how many of you do part of your research work out in the communities in Colorado? Okay, got a couple of hands there. Good. I designed the slides with sort of that response in mind. And so with that, we'll switch over into a little bit of background information, starting with our PBRNs. So right there, that's the top of Lookout Mountain out in Golden, wearing a yellow jersey on the final stage of the Tour de France in 2017. I did not win that race, in case you guys are wondering. So practice-based research is research that's developed through questions that arise through daily medical practice. And this is most often in the primary care setting, but not always. And this is a bit of a traditional but still valid definition. And part of the reason for how this definition came about is that in the 60s and 70s, when practice-based research was becoming increasingly common and codified as a research field, they were realizing that the guidelines that were being developed and disseminated from academic medical centers did not always match their own real-world experience. And there's not any sort of intention of deception or anything like that, but the patient population that we're seeing in community-based practices in primary care were oftentimes a lot different than the patients that we're seeing at academic medical centers. So a couple of the classic examples of this type of research would be the idea that every woman who is having an uncomplicated miscarriage would need to go through a procedure called a D&C to evacuate the uterus. The everyday family physician thought that that was a little bit excessive, but that was the best evidence they could glean from the studies that were being done at the academic medical centers, in part because the women who presented there were usually higher risk and more complicated. So they designed a study to test that theory to see if it was truly necessary or if they could be managed through expectant management and minimize an unnecessary procedure. And after that study was done and the results were published, Williams Obstetrics, one of the classic tomes in OB, actually changed their recommendation, and then practice changed to no longer do that as standard of care. So with regards to that, practice-based research has the potential to improve population health, close the gap, meaning translational research, increase the understanding of culture and disease, and decrease health disparities. This one is important because a lot of times our practices are out in geographic areas where the culture, racial, demographic, all sorts of other variables are different. And then another thing it can do is help connect clinicians and practitioners in small, particularly rural areas with the expertise of researchers to create a knowledge-sharing community. So in order to have practice-based research, you have to have a network infrastructure to support that. And the Agency for Healthcare Research and Quality has been one of the federal agencies that's been the largest supporters of PBRNs. And they've defined it as a group of primary care clinicians and practices working together to answer community-based healthcare questions and translate research findings into practices. So with our networks, the infrastructure requires some sort of a governance or steering committee, and we'll talk a little bit about what that looks like for our networks here in Colorado. And then a lot of times with our PBRNs, we'll work with PIs and other fields, disciplines, parts of campus to help to revise and adapt study designs, submit funding applications, collect data, analyze, publish, the whole research spectrum. And so a lot of times we'll partner with other folks on campus who want to get involved with a lot of the PBRN type work. Furthermore, a lot of times studies can originate within the community of practices, and those community clinicians will sometimes be PIs or co-PIs on these projects. We've even had some of our patient stakeholders serve as co-PIs on projects. So I like this quote here because it's exceedingly ambitious, just like all of us here. And basically, PBRNs can improve the health of all Americans. Doesn't that sound great? So within Colorado, Miles kind of alluded to this a little bit, but we have one of the strongest legacies of PBRNs here in Colorado. Initially, this started as the Family Medicine Information Systems, which was here in our Department of Family Medicine. And this was basically a way to abstract data from practices back when everybody was on paper. This was in the 60s and 70s when there wasn't any, sort of electronic health record, and to really capture a lot of phenomenon that happened in primary care. That evolved into the Ambulatory Sentinel Practice Network, or ASPN for short, so it's here from Colorado and it's called ASPN. And this one was formalized in 1978, and it had practices all over the U.S. and Canada, and was one of the first national PBRNs that later became the NRN, the National Research Network, housed at the American Academy of Family Physicians. And the director for the NRN still holds her faculty appointment here at the university and is here with her time. So we have that strong linkage to national collaborative of PBRNs. After ASPN moved over to the American Academy, we started our own PBRNs here within Colorado and took on the name SNOCAP, and that's the umbrella organization for all PBRNs affiliated with the University of Colorado. And there's been a lot of networks that have come and gone, mostly before my time, and so you'll hear some stories and histories around that, but there's 5 that are currently within SNOCAP that are doing a lot of research in primary care practices. So CareNet is the network that consists of practices that provide care to medically underserved populations. So these are the federally qualified health centers, community health centers, residency practices, any other primary care practices that are part of the medical safety net. Bighorn is the network that includes a lot of the small independent primary care practices or the health system owned practices. CocoNet is the Colorado Children's Outcome Network. They used to have the best logo among all of them, but now I rate them at second best. But this is our pediatric practice-based research network. High Plains Research Network is, as the name describes, and consists of all the practices in the High Plains of eastern Colorado. And that one has been around for a little over 2 decades. We just celebrated the 20th anniversary in 2017. And then our other geographically defined network is PeachNet. We decided since Eastern Colorado had their own network, we needed one in Western Colorado. But we needed somebody who lived in Western Colorado to do that. And this last year, we gained a faculty who practices and lives out in Grand Junction to direct that network. So PeachNet's the one I think that has the best logo. So this is a bit of a couple-year-old map, so you don't see any of the new PeachNet practices on, but it does show the general spread and location of all of our practices. So got the green practices of High Plains and Eastern Colorado. Scattered along the Front Range are a mixture of CocoNet, the pediatric practices, CareNet, the safety net clinics, and Bighorn, the small to medium-sized primary care practices. We also have a large membership of practices in CareNet in the San Luis Valley, which is that area that's just west of 25, south of Colorado Springs, and then a few members out on the western slope. And so our hope is over the next few years to really improve our membership out on the western slope of Colorado. So within practice-based research networks, there's a lot of different studies that we can do, and we have studies of all types going on right now. So a lot of observational studies. One example of one that we recently did in this area was looking at marijuana use in primary care practice, and we would survey patients and their providers simultaneously regarding the patient's use of marijuana to see how often providers were detecting it. Was it for medical, recreational uses, etc.? Then we also do a lot of experimental studies where we'll usually do a lot of pragmatic trials or cluster designs, the cluster being at the practice level, sometimes at the county or regional level. And those experimental designs are really helpful for translational research and sometimes as well dissemination and implementation research. And so with that, we're going to talk a little bit more about the translational research side. And this is one of the classic articles in the PBRN literature from 2007 that looked at PBRNs as blue highways on the translational sciences roadmap. It's kind of a bit dated in the sense that NIH has updated their translational science roadmap numerous times since this one came out. But the idea here was that to jump straight from bedside to clinical practice with that T2 translation was a pretty large leap to make, that you couldn't just do the bedside clinical research and actually publish the findings and expect it to end up into practice. And there needed to be some other steps, such as DNI research, other types of practice-based research methodologies, and that practice-based research networks are really well primed to serve as that intermediary between bedside and clinical practice to help the translation of evidence-based practices into the communities that are served by these clinics. We've also since expanded the horizon to include a lot of community engagement work to not only facilitate that translation into practice, but also that T4 translation that goes into communities as well. And so with that, we're going to shift and talk a little bit about community engagement in our PBRNs. Part of the reason I love doing community engaged research is that it takes me all over the state of Colorado. So this picture right here comes from the Great Sand Dunes National Park down in the San Luis Valley just outside of Alamosa. And you can kind of see the little river and dunes and coming right over with the sunset there. And so this was actually part of a work trip. So, if you guys want to do community research, you can get out there and see these sites. So with our community engagement program in our PBRNs, we have this at many levels, including the network governance and operations, as well as organizational partnerships. So with the organizational partnerships, I've worked in the last year with both 2040 Partners for Health and the Colorado Coalition for the Medically Underserved, which is now renamed as the Center for Health Progress. And these are community-based organizations that are wanting to participate in research projects where we can lend our research expertise to help them to move a lot of their interests along. With regards to the network governments and operations, we have advisory councils and CareNet and High Plains Research Network. A steering committee is being formed for PeachNet, hopefully if a PCORI award gets funded. And then CocoNet has several parent working groups to help establish their agenda for their pediatric research. And so this is just proof that we do have folks to advise us. So on the top, we have the Community Advisory Council of the High Plains Research Network, along with the director, Jack Westfall, and co-director, Linda Zittelman. And then here's our Patient Advisory Council for CareNet. And so some of these members have been serving on the Advisory Council for over a decade to help design research questions, submit proposals, be involved with the research process, and help with the publication and dissemination of the results. So these are expert patients, as we sometimes call them. This highlights all the different ways in which the patients and community members can be involved in our research work. And one thing we're going to focus on a little bit is this idea of intervention development, and one particular methodology called bootcamp translation. So bootcamp translation is a method that was developed in the High Plains Research Network in Colorado. And the definition that's more or less been settled on is a process by which academic researchers and staff and community members partner to translate evidence-based medical information and jargon and clinical guidelines into concepts, messages, and materials that are locally relevant, meaningful, and engaging to community members. So with that, we'll talk about how this process was initially developed. So it was with a project that was funded through the CDC with Jack Westfall and the High Plains Research Network. And the CDC was interested in understanding how they could improve screening rates for colorectal cancer in rural areas. So they successfully obtained a grant to study this. And once the grant was funded, he worked within the Community Advisory Council for the Research Network to just basically went to them and asked them, like, how could we get this word out to the farmers, ranchers, teachers, everybody in our community so that they'll get screened for some sort of, with some sort of test for colon cancer. So the Community Advisory Council said back to him, well, what are the screening tests? Why should we tell people to do that? What's the data behind this? So they invited an expert to come out, and they gave what was more or less a CME presentation at the time to the Community Advisory Council and really slowed it down and spent about 4 to 5 hours unpacking it. And with that, they then took the information that they learned and developed a set of messages and materials for rural eastern Colorado around testing to prevent colon cancer. Even the idea of using the words testing to prevent colon cancer came from the Community Advisory Council, where they said screening doesn't really make any sense to us. Is it a test? Why don't you just call it a test? And the initial language was around colorectal cancer. And they're like, do we have to call it colorectal cancer? Can't we just call it colon cancer? That sounds a lot, easier to talk about than colorectal cancer. And in addition to changing the language, they also developed a set of materials, and these are just some of them, to try to get the message out there to eastern Colorado. So in the corner here is the farm auction flyer, which I don't know if any of you guys are from rural areas, but this is kind of the big deal out in rural eastern Colorado and other rural parts of the U.S., where the farm auction flyer kind of tells you all the community events, what's happening, who's selling the tractor, what's going on at that farm down the road. And what they did was they took what was a typical farm auction flyer at the time and then embedded health messages within it, including, information about colon cancer, a call to action to talk to your doctor. So people would grab this because at first glance it looked like a flyer, and then they would read it and get health messages about colon cancer. They also had these posters that were distributed across the community with folks that actually lived in eastern Colorado and were somewhat recognizable to folks in the community with some of their key messages. So they developed 4 key messages through the process, which are featured on the poster here. Colon cancer is the second leading cause of cancer death in the U.S. It is preventable. Testing is worth it. Talk to your doctor today. So you can kind of see with these messages that there's the element of local flair, so to speak, that did not really line up with a lot of the slick national campaigns at the time to try to encourage testing for colon cancer. So at the end of this process, they showed an absolute increase in the intervention region of about 9% of people that were getting screened, as well as an increase in intention to be screened and an increase in being up to date with a screening method. Furthermore, this paper here was published by the Community Advisory Council and shows their involvement in the project from very early on all the way to the dissemination of the results. And so after that, the process of boot camp translation has more or less been used several hundred times, a variety of health topics, mostly in Colorado, but other parts of the U.S. and the world. So we're going to shift with that in mind to talk a little bit about HPV vaccination. So does anybody recognize where this photo is from? So this is Grand Junction in the downtown area. They've got some nice street art and sculptures over there. This one, of course, being of a bicycle. So why are we talking about HPV now? Burden of disease, there's over 30,000 cases in the U.S. each year, and it's highly preventable. There's over 120 different types. Most infections are asymptomatic, so most people won't know if they have the virus, and almost everybody is exposed at one point in time, 80%. A lot of people do clear the infection with their own immune system, but a lot of folks can go on and develop cancer. It's linked to several different cancer types: cervical, vulvar, vaginal, penile, anal, as well as mouth and throat cancer. And interestingly enough, the oropharyngeal cancers, or the head and neck cancers, are projected to exceed cervical cancers in the coming years. So you can see the pink line here on the graph is cervical cancer, which is on a decline in part due to vaccination, in part due to the screening practices available. But oropharyngeal cancers in men, as well as overall, are projected to increase the burden of disease from cervical cancer. Part of the reason for that is there's no screening program or practices in place to screen for oropharyngeal cancers. However, our vaccination rates in Colorado overall are very low. So you can see here the 2020 goal for Healthy People 2020 is 80%. And that includes a goal for all the adolescent immunizations, so HPV, Tdap, and meningococcal. Meningococcal and Tdap have hit that 80%, but HPV continues to lag, both in the U.S., which estimated rates in 2015 were 42%, and Colorado, where the estimated rate was 46%. You can also see that there's a lot of county-to-county variation, with the darker counties showing a higher vaccination rate than the lighter ones. The story is similar for men, and both of these maps are looking at 13 to 17-year-olds that have completed the series. The data is from 2015 and does show 3+ doses, in part because that was the recommendation at the time, was to have a 3-dose series. The 2016 data and moving forward will likely change after the new recommendation has been out, so that's why there's not anything a little bit more up to date right now. But what the story kind of shows is that if we want to get to the 80% coverage rate in essentially what's 2 years from now, that our current practices of just letting this information disseminate and diffuse is not necessarily going to work, because the uptake has still remained pretty low in the communities. So if we look at the rates by some specific counties here in the metro area, we can show that Denver is really the best off at 53%, in large part due to a lot of the initiatives from Denver Public Health. But still 53% is lower than the Tdap and meningococcal rates and where we need to be. Another way to kind of frame this up as well is to look at cancer preventive services that we can deliver in primary care. So Pap test screening for cervical cancer, the rates are almost at 90% and have been somewhat of a plateau for about 15 years. Similar story with breast cancer screening with a mammogram, rates at about 80%, stable for about 15 years. Colorectal cancer screening has been on the increase over the time, and in 2015 it shows rates that are approximately 60%. So We know that folks are getting the other vaccinations, but not HPV. We know that folks are getting other cancer preventive services, but not HPV. So what can we do to try to address that issue? So my thought was to go with community engagement strategies based on a lot of our previous work that we had done around those in our PBRNs. Part of the rationale for why this should work, or why this might work, would be that 30% of adolescents never present for preventive care. 1 out of every 15 visits is for preventive care. The majority of them are for acute care or episodic care. And then once kids turn 13, they kind of fall off as far as having their annual well child exams. We also know that community engagement strategies and community-based participatory research has been shown to increase the translation of evidence-based interventions into practice. That's one reason why all the CTSAs, like our CCTSI, has their own community engagement program to help with the translation of evidence-based practices into the communities that they serve. However, for HPV, there's not been a lot of previous engagement work done. The closest you could come is some focus groups with adolescents and their parents, as well as some social marketing campaign, but that's considered a pretty low level of engagement where they're not partnering with the researchers on the project. So at that point, kind of the broad hypothesis in my mind was that community engagement can help accelerate the translation and uptake of HPV vaccine into Colorado communities. And so help us to get to that 80% mark that we need to get to in order to really reduce the burden of HPV-related disease as well as HPV-related cancers. So like any good scientist, once I had a hypothesis, I turned to the reputable source, The Onion, and I found out that there's a new step in the scientific method called seek funding. And so after making an observation and forming a hypothesis, the third step is now to seek funding. So that's what I did. So with that, got some grant funding from the American Cancer Society's institutional research grants here. And this was to really start to test that larger hypothesis by starting somewhat small and looking at if it would be possible to even just implement boot camp translation in 2 Colorado communities, 1 urban, suburban, and 1 rural. The idea behind this is that, colorectal cancer might have its own set of stigma and issues around it, but certainly HPV vaccination does, and we didn't really even know if people would want to come together and talk with us about it. It's kind of a private topic. Definitely have to talk about sexually transmitted infections whenever you talk with folks about it. And in some of the communities, that can be a hard conversation to have, particularly as outsiders coming in from the university. The second one was then to look at how the process of bootcamp translation influences the participants' knowledge, attitudes, and overall engagement. So part of the reason we think bootcamp translation works is because we bring the health topic expertise and present it to the group of community members who have expertise in their own community. And these community members then become relative experts on that health topic. So they develop a lot more nuanced understanding of whatever the topic is than they used to have and their neighbors. However, we wanted to test that to see and make sure if that would happen. So for the bootcamp translation groups, we typically target anywhere from 10 to 15 individuals. And for our areas of interest, we decided to focus in Mesa County and then in the Denver-Aurora metro area. With Mesa County, the story was that we had PeachNet, one of our new networks that was forming out there. And it was always a good idea when you get a new network to try to launch a couple of projects to try to show examples to the community of what you can accomplish with having this new network. So the environment was very ripe out there. For the Denver-Aurora area, we had initially steered a little bit away from that just because of a lot of the saturation from other resources in town, such as Denver Public Health, and looked at trying to partner with folks in Larimer County. However, in Larimer County, it ended up being a bit of a non-starter with the community, kind of like we had thought might happen, and it was hard to recruit people who wanted to come to a meeting. Folks were very comfortable talking one-on-one, but not necessarily in a community setting. So then we shifted our focus to the Denver-Aurora metro area. Within each group, you can kind of see the composition here, but we had parents, teenagers, health professionals, cancer survivors, clinicians, firefighters, leaders from different communities. So a bit of a motley crew, but that's exactly what we go for. And part of the reason for that is that usually whenever people are forming groups or coalitions to address health issues, they tend to go for the experts. And so we always say that for our community engagement work, we look for the folks that are not the usual suspects. So the folks that aren't necessarily already very well-versed and knowledgeable and passionate about the topic, but folks that really know their community very well, and we can bring them up to speed on the health side of things. So with regards to that, of all the participants we had, 85% had heard of HPV prior to starting out. 90% had heard about the vaccine, which I found interesting. There was one person who heard about the vaccine, but not the virus. Most folks knew that it caused cervical cancer, but only 45% were aware that it caused oral or anal cancer. And we asked about their attitude as well. And you can see here that these were not necessarily a group of folks that all believe very strongly about vaccination. So they did believe that there is necessary to prevent certain diseases. 79% were confident or somewhat confident about their safety, which is not particularly high. And with regards to getting multiple shots in one visit, 20% thought that it would overwhelm the immune system, 50% just didn't know. So I imagine if we looked at this among a group of professionals, the rates would be a lot different than we saw within our community members. So this diagram here depicts the boot camp translation process, where we start with a full day kickoff meeting. And that full day kickoff meeting consists of that expert level presentation. I'll talk a little bit more about what that is on the next slide, but that's really to give everybody the expertise on the health topic area and then shift into brainstorming mode. And then between the series of these 4 meetings that occur, there's usually 2 to 3 30-minute conference calls where the facilitators for the BCT can help to really get consensus and drill down on very specific items. And then we reconvene as a group to kind of review the progress, expand and brainstorm a little bit more, contract again over the phone calls until at the very end we end up with messages and materials that may be somewhat similar to what we've showed you already with regards to the colon cancer campaign in Eastern Colorado. So kind of like I mentioned at the beginning, the kickoff retreat, we do the very slow introductions. It usually takes 30 to 45 minutes to go around the room and really get to know everybody. For this talk, for our groups, we actually adapted a CME presentation that was given through the American Academy of Pediatrics. Some of those slides I used at the beginning of this section on HPV were taken from that presentation as well. So we didn't necessarily, dumb it down or anything else like that. But what we do is instead of having a 1-hour talk, we give it over 3 hours and allow people to ask questions, really define every term as we go along because we want people to become experts in the area. And then we start the brainstorming process about what does our community need to know. And this is usually, what do they need to know in order to increase the uptake of the HPV vaccine? Or what do they need to know about HPV to make informed decisions? And really try to get the community members involved around this. So with Mesa County, they currently have had 3 of their 4 in-person meetings, and they've decided upon 2 target populations. So parents of children ages 9 through 14, so the ideal vaccination age window, as well as adolescents and young adults making their own healthcare decisions. And this target population came from the teenagers in the group who were saying that, they knew folks whose parents did not necessarily want them to be vaccinated, but they might want to. And once they're able to start making their own healthcare decisions, they might want to get caught up on the vaccination series by themselves. And so they wanted to focus the materials into those 2 different target populations. And so for the parents, that they're really looking at doing is some sort of a poster or picture with the message that says, "Don't let will wait turn into too late. vaccinate against HPV now. And this was the idea that there's a lot of hesitancy in the Mesa County community around HPV vaccine, and this idea that you could put off the decision for year over year, not necessarily say no, but just say not right now, this doesn't fit for my kid right now. And the idea behind it, the poster is to have sort of the 9-year-old child that would be eligible for the vaccine on the Will Wait side, and then on the Too Late side depict a cancer survivor. And we're going to try to get some photos going of local cancer survivors to help with this campaign. They also really wanted to make sure that they had several versions that included both boys and girls, as well as white and Latino populations, because that was largely representative of what the population looks like in the Western Slope. The adolescent and young adult campaign is looking at a primarily social media platform, so Instagram, Facebook, or Snapchat, with this message that adulting is hard, cancer prevention is not. I can guarantee you guys 100% that we would have never thought of putting the word adulting into any sort of health message. But this is what the group wanted, and so we followed their lead and decided to go forward with that. They really wanted to expand upon the idea that HPV is a sexually transmitted cancer and that it's preventable. Given that they're using social media, they wanted to tag on to the hashtag HPV vaccine that's already in use and commonly done out there. So right now we're in between the third and the fourth meeting, and we have these preliminary materials that have been developed. So what we're doing at this phase of the process is giving this back to the group to review and look at to make sure it's capturing what they had envisioned whenever they had given us this idea. We've gotten a lot of feedback so far that this is not what they wanted, which is perfect because that's what we want to hear from them. That the images don't really fit, that we need to really refine those. The messages are a little bit closer, but that we need to not do black and white, get something a little bit more colorful and something that appeals a little bit to the teenagers and young adults. Like this idea of the people holding hands, they thought that those looked like really old folks by comparison. For our group here in the Denver-Aurora metro area, we've had two of our meetings, so right now we're really trying to drill down on what we can turn over to a designer. And the key messages that we have are that HPV causes cancer in boys and girls, statement of the prevalence and incidence of cancer, some knowledge about the vaccine, and then a call to action that says ask your doctor for the vaccine. And what we've talked about was trying to target parents of elementary school kids that might be hesitant, but not necessarily like an anti-vaccine lens. And really trying to target folks that don't know about the HPV vaccine and trying to find folks that are at risk for having lower health literacy, such as low-income families with less resources. So our next steps. Moving forward, both of these groups, we're working to finalize the materials in the next few months, and that section of the project will be done, and we'll have some locally relevant materials around HPV vaccination. We've also are looking at expanding our community involvement, and we currently have a partnership development grant under review over at the CCTSI, looking to partner with Larimer County on developing community partnerships to help address this issue. So this kind of came out of the project from where we had a lot of difficulty with engaging folks in the project early on to then decide that we needed to do a little bit more of the boots on the ground partnership development work. We also are looking to test the efficacy of the approach. So this was largely to develop the messages and materials, but not with a one-year study timeline, not to actually implement the materials and look at their efficacy with regards to vaccination rates. So we have an R21 under review to look at that exact issue, and that will be within our snowcap practices. And then once the boot camp translation materials are finalized, our goal will be to disseminate and then hopefully evaluate the finalized projects. And we're talking about looking at a PCORI award to help do that. So to really kind of test a little bit more of that hypothesis that now that we've engaged community members in the process, that their work is actually going to help to accelerate the uptake of the HPV vaccine. So that's kind of where we are right now, and we'd be happy to take questions on the specific project, how we work with communities, or just about our PBRNs in general. Yes.
Is there any, sorry, is there any community engagement practices or programs that combat the kind of this anti-vaccine perception that's kind of growing out there? For instance, when a famous movie star comes out and says, this gave my child autism, is there ways to kind of combat that notion? Is there anything in place to kind of combat that out?
Yeah, it's a good question. The question was about any community engagement strategies just to address the idea of anti-vaccination. And so our director for CocoNet, the pediatric PBRN, is Sean O'Leary, and his expertise is around vaccination research. And with their parent working groups, they came up with what was exactly that idea of how to address anti-vaccination. And so we're working together to how we can engage parents and other folks in the communities to try to address that. So that's kind of another sort of project that's along these lines that we're working on doing. So nothing yet, but stay tuned, and is definitely on our agenda.
I was going to ask you, so it seems like it is a pretty good process for dealing with single interventions. I think very much experience with getting sort of a group of interventions together and educating everybody else.
Mm-hmm. Yeah, exactly. So question about sort of instead of just doing single intervention studies, combining multiple interventions a little bit. So some of our PBR researchers have done a project looking at multiple different interventions, including motivational interviewing and other things in the practice. What we're talking about doing is combining the practice-focused intervention with the community-focused intervention and testing that out. So including some of the community developed messages and materials to help increase the conversation and dialogue on the community side, and then implement some of the practice level interventions simultaneously to see if that combined approach, do we have an additive benefit, and does that work better together? And so that's one thing we've talked about for maybe a PCORI kind of comparative effectiveness type of research.
Do you have any idea how you would follow up longer term to figure out, the HPV-related thing, whether or not HPV-related cancers are declining?
That's a good question to really find out so we care a lot about vaccination rate, but the real outcome here is the cancer itself, right, to prevent the cancer. And so not a lot of thought on that yet, and so probably why we'll continue working together, Miles, to try to be able to capture that longer term piece.
I mean, the cancer registry will tell you what's going on in the population, but you won't necessarily be able to link that directly to benefited from your intervention. So it's interesting to set up the cohort and follow up through the area.
Yeah, that'd be awesome. Yeah. Yes. Mm-hmm. Yeah, our goal is, so definitely for the group in Mesa County, they want to include boys and girls to try to get at both sexes, and then really focus on the two most prevalent ethnic groups there, the non-Hispanic whites and the Hispanic whites. For the group in Denver, there's been a lot of preliminary discussion around that. Denver has a lot more diversity, and so there's nothing that's been completely settled upon, but we have one of our participants as a leader in the Asian refugee community, and he really wants to have some sort of talking points or information to give to his community. And so that would be a bit of a process to making sure that whatever we have resonates within that group of folks that might have limited English proficiency among other different cultural barriers. So to kind of answer the question, it's on our radar. We don't have necessarily like a formal plan or process in place around cultural adaptation, though.
Is that something that came up with the
Yeah, yeah, I did. So since I was in Eastern Colorado, they had translated into Spanish for the Latino migrant farmers and workers that live in Eastern Colorado as well. And so, the one thing that I still remember very well was they created a little thermal coffee mug, and it was during the time of the Got Milk campaign. And so on that mug, they put the message "Got Polyps" to kind of start the conversation. But the people that were from the Latino community really wanted to have it in their language, and so they made a mug that said "Tiene polipos" to try to get the message out there. All right.
Okay, great. Thanks very much, man.
Yeah, thank you guys.